Well, hello, everyone. On behalf of the AVAHO executive leadership and the AVAHO board, I welcome you to the first of a series of three presentations that have been prepared to discuss key considerations involving VA. Our goal is not to politicize these discussions, but to highlight many of the good things that the VA has done in U.S. healthcare over the past 50 plus years and to ensure that these key values continue beyond 2025. My name is Rusty Crawford, and I am a former AVAHO president from 2018, and I spent my entire pharmacy career within VHA with a focus on oncology pharmacy. When I first started working for the VA in 1988, there was a clearly defined mission statement, and to this day, I can still remember where the priorities and focus were in that statement. Those of us who have made a career serving our veterans are understandably concerned when we hear talk of privatizing the VA and that community care and VA care are interchangeable and equivalent. Again, without being political, we hope to demonstrate why this is not necessarily an accurate statement or mindset. So, what are those values that got VA where it is today? Where do they fit in the future? That will be the focus of this three-part series we have developed with a target audience of AVAHO members, VA employees, veteran service organizations, our sponsors, and our elected officials to clearly see and hear what VA healthcare has done for and added to U.S. healthcare that may not be fully understood or appreciated. The three sessions will focus on three of those key mission statements from 1988, which should still hold true today. First is the continued provision of high quality, patient centered healthcare for our veterans, which will be the focus of today's discussion. We will have a second session with VA oncology experts that is looking specifically at what the VA is doing for oncology patients that they serve. The second session will focus on the role of the VA as the nation's leader in healthcare professional training and education. And the third session will be the history and the importance of VA being a leader in clinical research that both individual patients and healthcare systems benefit. And with that, I will introduce our two moderators for this session. First is Ms. Mary Thomas. Mary, prior to retiring in 2020, was a clinical nurse specialist in hematology at the VA in Palo Alto, California for a 35-year career. She was also an associate clinical professor at the UC San Francisco School of Nursing, a member of the VHA National Nurse Executive Council through the central office, and co-chair of the Advanced Practice Nurse Advisory Group. Mary was my mentor and is also a former president from 2017. We also have Ms. Julie Lawson. Julie has served as the executive director of AVAHO since 2017, helping guide the organization to continually improve what the organization provides for its members and how it benefits our veterans with cancer. Prior to joining AVAHO, Julie has spent her career in nonprofit work and activities that focus on advocacy and support within her community. I will now turn over the microphone to these two ladies who will introduce our first panel of professionals with a career of commitment to healthcare, the VA, and our nation's veterans. Mary and Julie.
Thank you. Thank you. I know we have a handful of questions we are eager to ask these esteemed guests today, and so I welcome them and I welcome everyone who's watching to learn more about the history of the VA and the importance of the work that the VA does. With that, I'll let Mary take the first question and I'll join in a moment.
Thank you, Julie. So, to begin, we will ask each of our esteemed faculty to introduce themselves as they answer our first question, which is to share with our audience very briefly your background and also your involvement in VA healthcare. So, we'll start with Dr. Suzanne Gordon.
So I'm not a doctor, but thank you, Mary. I am a healthcare journalist and author, and I began working with VA probably in 2007. I write a lot about teamwork in healthcare, and I was asked to consult with VA in Palo Alto about some team problems they were having. I knew nothing about VA until then, and spent about 6 months there, and I was super impressed by the kind of care, VA gave to patients, and really impressed by the accountability and responsiveness to patients' needs. If there was any problem, they would have a congressman come in and do a congressional investigation. And, if I had a problem with my doctor in the private sector, like, good luck. So I thought that was really interesting. And then in 2014, I cooked up an idea to write a book about VA healthcare, which eventually turned into a book called Wounds of War: How the VA delivers health, healing, and hope to the nation's veterans. And I spent probably 5 years in VA facilities all over the country, and was very impressed by impressed is really not a good word. It was just bowled over by the kind of care that people got, and I saw it firsthand. And that was right at the time when the move to privatize the VA started. And I was extremely concerned about that, and be co-founded something called the Veterans Healthcare Policy Institute, which has been very involved in trying to fight VA privatization, and also trying to get out the word about what the VA does. I agree with Phil Longman, who that it is best care anywhere, everywhere. And we should all benefit from that care. I see the VA as a model of the kind of healthcare that we should all be able to access, and that should really replace the broken healthcare system that we have today, which I and many others, most Americans, have to navigate. And so I'm very excited to be on this program and get the word out with you.
Great. Thank you so much. Now let's hear from Phil Longren.
Hey, thanks. Well, it's an honor to be here. Um, my my experience with the VA started in 1999 when I lost my wife, Robin, to breast cancer. And as part of that ordeal, I became very interested in how quality in healthcare worked, and how sometimes didn't. And so uh, at the time, I was a journalist working for U.S. News and World Report. I had a long-standing interest in healthcare policy. Um, Fortune magazine asked me at that time to sort of take my experience and use it to tell a story, help tell a story about who actually had the best healthcare in America. So I went about in great earnestness trying to figure out who did. And this was a period in which quality metrics in healthcare were first starting to be developed. And so I went around and I talked to the various experts in the field about who had best care anywhere in the United States. And it turned out that I kept hearing this answer over and over again. They said, the most innovative guy in American healthcare today, and the most innovative institution in American healthcare is the VA, headed at that time by Ken Kaiser. And I could not really believe that answer because, like many Americans, I had a kind of received idea that the VA was a mediocre institution. And all the headlines about various scandals over the years. So by reputation, I did not have the VA did not come highly recommended to me. But I came to see, both by talking to experts and then eventually researching and writing a book about how the VA worked, and the very inspiring story about how it actually invented itself as a really first-rate institution, healthcare provider. I got religion, and so I wrote that up in a book called "Best Care Anywhere," that describes this turnaround that the VA experienced starting in the 1990s, and how uh, by the time I was writing about it in the mid aughts, it really was, by just almost every measure: patient satisfaction, medical safety, adherence to protocols of evidence-based medicine, on and on, just delivering really first-class healthcare. We can talk about why that happened and how it happened and how it's now threatened. But that's basically my background and how it came to be involved with the VA.
Great, thank you so much. So posing this question to both of you, talk to us a little bit about the existing data that compares the VA care to community care, especially in terms of outcomes.
I think on every measure, there have been a lot of studies comparing the VA to Medicare and private insurance, folks with Medicare and private insurance, and the VA care pre the outsourcing movement that started in 2014. And it's really almost impossible to detail the reams of studies that show that VA is equal to, or very often superior to, private sector care. And we can talk about the reasons why in a minute if you want. But starting in after the Choice Act was passed in 2014, and particularly after the Mission Act was passed in 2018, and that set up this parallel private sector network to which 60% of veterans are now funneled often, and that has 1.7 million, probably more now, private sector vendors, essentially contractors. Now we have the ability to study veteran to veteran in the private sector and in the VA. So it's really kind of apples and apples. And that's pretty important because veterans, as you know, are more complex patients than the average private sector patient. And we probably should talk a little bit about that. And so you see that the studies document very clearly that private sector care is often inferior to VA care. And let me just cite a couple studies. There was a very important study that was done on veterans who were duly eligible. That is, they have Medicare and VA care. And they had a medical emergency, and were taken by an ambulance pretty much randomly to either a private sector hospital or a VA hospital. And I think it was something like 500,000 ambulance rides. And the veterans who were taken to a private sector hospital were twice as likely to die in the first 28, I think it was, days than those taken to VA hospitals. And what the researchers called the VA advantage, lasted for an entire year. And that's because the VA has coordinated care. I mean, there was coordination from the instant the veteran went into the VA hospital, between primary care and so forth. And what was also interesting was, for the privilege of getting more dangerous care in private sector hospitals, the VA had to pay 21% higher costs. And we see that in oncology care, if you have clinically insignificant, and I'm not an expert on this, you all are, clinically insignificant prostate cancer, and prostate cancer is the biggest, solid tumor in the VA. They have a lot of prostates in the VA because a lot of men. You're more likely in the VA to get standard of care, which is surveillance and watchful waiting, than in the private sector, where you're more likely for this to get invasive chemotherapy or surgery. As Phil said, it is best care anywhere because it's VA doctors and staff are on salary. They have no incentive to give you a radical prostatectomy or, a hip joint replacement when you could get PT, because it doesn't enhance their bottom line, which it does in a fee-for-service system, which is what we have outside the VA. And I'm sure Phil can add to this.
Okay, Phil?
Yeah, I think so we can cite endless studies, right? But to me, I kind of needed a story to explain why we kept getting these results. And I think the thing that explains it is that the VA, for all of its faults, is almost unique in American healthcare and having nearly a lifelong relationship with its patients. So like, it typically begins, when somebody leaves the military, often still in their 20s, and extends onto long-term nursing home care. So this means that as an institution, the VA actually has an incentive to keep people well. Because, for example, if it doesn't manage their diabetes well, right, it's on the hook 10 years down the line for all the complications of unmanaged diabetes. It actually has a financial incentive to get people to stop smoking because that saves them money, right? This is very different than what exists everywhere else in the American healthcare system, where people are on different healthcare plans and they churn between those plans quite rapidly, typically every 5 years at most. Most of us are on a new healthcare plan. That means the people managing these plans and delivery systems associated with them, don't have they actually have a disincentive to invest in prevention, care coordination, anything that brings long-term benefit because that costs money today to actively manage somebody's diabetes or to get them to quit smoking or whatever. But the return on that investment, as it were, doesn't go to the people making it. It goes to some other healthcare plan down the line. And so that creates this like built-in incentive for the VA, right, to align it, or it aligns the interests of the VA with that of its patients in a way you just don't find anywhere else. And that I think is one of the big factors involved in this care coordination. The VA, it's telling that the VA invested in electronic medical records, uh, 2 decades really before the rest of the American healthcare system did, because it had an incentive to take advantage of all the care coordination and evidence-based protocols of care that involved. It basically pioneered the concept of medical error. Coming into the 1990s, the rest of the healthcare system didn't even have the concept of medical error, let alone any kind of systematic attempt to root it out. The VA did. The other big thing I would mention is personnel. So the VA is itself a sort of self-selected population of people who have a particular commitment to veterans and who have a commitment to doing medicine for reasons other than profit maximization, right? So if you go to work for the VA, you're going to make less money than if you go to work for somewhere else, but you're going to be able to adhere to a sense of mission. And so that means that in the aggregate, you've got among clinicians and everybody else in the system, a great deal of esprit de corps, frankly, that you wouldn't find or don't find much in other places. So practice medicine without having to think about profit, and that's a huge thing, I think, in explaining this overall performance superiority of the VA. Suzanne can back me up on that even today, with all of the attacks on the VA and the defunding of the VA that's occurred, it's still delivering, by most metrics, care that exceeds that of the private sector in general, including on things like wait times.
People actually talk to each other in the VA. When you see care coordination in the private sector, what passes for care coordination is people putting notes and charts and other people reading notes and charts. That's not care coordination.
So why do you think that the lack or the challenge of care coordination in the community it has the potential to impact timeliness of care, communication, and most importantly, quality of care?
Well, care coordination is it if you have complex patients. If I were a patient in the VA, there would be a pharmacist in the primary care clinic who could answer my questions about how to take my meds. And I ended up not getting the questions answered. It was a urological problem, and I ended up getting an infection because they didn't know how to talk to me.
I think the normal practice of medicine in the United States varies a little bit regionally, but typically, right, we each get passed from specialist to specialist who deals with one organ at a time, and nobody is looking at the whole patient over time. I mean, there's a whole body of literature that suggests that up to like the third leading cause of death in the United States is contact with the US healthcare system, when you count all the different medical deaths resulting from medical errors, from unnecessary surgeries, from other forms of inappropriate care and uncoordinated care. You know, it took me a while to understand that when we say best care, what do we mean by that? What is quality in healthcare? Quality in healthcare is not just going to the doctor with a diploma from the most prestigious medical school you've ever heard of, right? It's a whole system of care. Is at war with this thing that made the VA so great, this coordination of care. Because that's the first thing you lose when you put care into the community, is that care coordination.
So you both have answered this question in part. When we are now faced with increased reliance on community care delivery, what is your opinion on how that has affected outcomes? You've talked a lot about how it's affected care coordination, continuity of care, but how has it affected outcomes?
I think people inside the VA who are viewing this understand how complex these patients are. I mean, we talk about care coordination, right? Care coordination is important to any patient, but it's particularly important to complex patients. The other thing that the VA offers is not just care coordination, but kind of one-stop shopping. So my friend, the Iraq vet, told me, to deal he can go to the VA and get 2 or 3 or 4 problems solved or addressed in a day. I think that it is not surprising that we see these outcomes that are poor. There was a study that was recently released that talked about patient dissatisfaction in mental health care in the private sector in the community care program. Another thing that I really want to point out, because this has been ignored, is that one of the things that means a lot to patients in the VA is camaraderie. They had camaraderie in the service. They feel its loss when they become civilians. They regain that camaraderie in the VA. And there was, in fact, a recent study that a scientific study that showed that camaraderie is very important to veterans, and I would argue important to healing.
That's probably more up to date on the very latest studies, but my understanding is that surveys of quality in care done by Centers for Medicare and Medicaid Studies Services and other third parties continue to show the VA having these superior outcomes. So that's just a brute fact. Veterans who use the VA, um, there's overwhelming support for its care, and the issues involved, some of them are real and difficult. I served on the commission for care about, what was that, 5 or 6 years ago, where we were charged with um, by the president and by the leadership in Congress to come up with a plan for saving the VA. There are issues of access, legitimate issues of access. The VA has always outsourced lots of its care as appropriate. Some of these issues are legitimate, and when I was on the commission, we tried to find criteria and rationales for when we would and when we would not outsource care to the community. But I think what's happened is there's been a kind of collapse of political support for the VA, and both parties have kind of participated in a mindless privatization without quite understanding what's really going on. And so I think real damage is being done to the VA, and a lot more is about to be done to the VA on current course. And again, this is not a partisan thing. That both parties have very much involved in this trend of outsourcing, inappropriately outsourcing care. But I am here to tell you that everything I know from studying this system and many other systems, from teaching healthcare policy at Johns Hopkins, as I did for a long time, the VA, the old model of the VA, there was nothing broken with it. It was something that the rest of the system, the healthcare system, needed to learn from, and to some extent has learned from. Like I said before, the VA was a pioneer in the use of electronic medical records. By now, since in the 20 years since I wrote the first edition of my book, the VA, the private sector is almost caught up to the VA in its use and integration of electronic healthcare records. Still isn't really there. There's other things on medical care and other things where the private sector is stumbling, getting closer to as good as the VA, but still not there. And meanwhile, this best care anywhere model that we have, we're actively deconstructing it. So it's quite a dramatic moment we're at, not just for veterans and veterans healthcare, but for the healthcare system of the United States generally. One other point, if I might just interject, elsewhere in the healthcare system, right, we have this tremendous monopolization going on. So hospitals are merging with each other. Hospitals, insurance companies are merging with each other. There's gigantic growth of highly concentrated corporate medicine in most medical markets in the United States today, which means that in many places, the only existing competition between providers that remains is the VA healthcare system. Like if you're in Pittsburgh, right, there is one entity, the University of Pittsburgh Medical Center, that controls virtually all of the hospitals and all of the insurance market too. The only competition to that system remaining in that market is the VA. And that competition provided by the VA to the rest of the healthcare system is actually beneficial to all of us, because it helps to keep the rest of the healthcare system honest, as it and to at least temper the terrible effects of monopoly that are just kind of running rampant throughout the rest of the healthcare system.
So when patients, veterans seek care within the community, either because the VA cannot provide that care, they're outsourced, or they elect to receive their care in the community. Does the VA provide adequate oversight for this care delivery when the veteran is not receiving all of their care within the VA system?
No, because it can't.
We commissioned a whole bunch of studies about what this kind of care would outsourced care would cost, right? And it turns out it's way more expensive than staff provided care, largely because of this, unrestrained, no utilization review, and also because you've got profit margins for these providers, you got to cover that too, right? So it's for those taxpayers out there listening, right? This is a really expensive model, right? So it combines high cost with low quality, right? It's like hard to beat, right? So yeah, that's kind of where we are with that right now.
Okay. Question for Suzanne, and you've alluded to this a bit. There are challenges with community care providers being adequately trained to deal with some of the issues that may be more specific to the veteran population. You've already addressed, or at least discussed, mental health care as being one. Spinal cord injury comes to mind as another. What do you think are the problems with folks not receiving the adequate amount of education or training to deal with these sorts of issues? What happens to the veteran when they don't have that level of care training?
Well, it's kind of important for your therapist, your PG, your OT your medical doctor, your NP, kind of know about the problems that you have. And, you know, Phil talked about this. I mean, I think one of the, I think that there's a lot of villainy going on out there in this outsourcing movement, but there's also an enormous amount of enormous amount of ignorance, because the people making legislation for the VA do not know anything about healthcare. And the healthcare that they themselves have experienced, they've had no experience of coordinated care. They have no idea what that means. They think healthcare means, you know, a series of doctors, a series of exam rooms, a series of hospitals. Patient is a patient is a patient, you know. I mean, Doug Collins said in his confirmation hearing, we give oncology care every day outside of the VA. What's the difference? Well, you know, there is a difference, and you need to be trained to understand what those differences are. For veterans, this thing called military cultural competency, which sounds very PC and kind of woo-woo, and what is that? But I've learned, and I'm sure Phil has too, because when you start kind of hanging out at the VA, start hanging out with vets, kind of matters to them if you don't know what a DD-214 is and what an MOS, military occupational specialty, you know. I mean, these jargony things, like, they matter to these vets, right? You know, they weren't in combat. They don't know what MST is. I mean, how many private sector providers, if you say MST, know what that means, right? Military sexual trauma. 1 in 4 female vets has experienced it. We should really get into the impact on women veterans, and what the VA has done to women veterans, and what are the particular problems of veterans. I mean, how do you distinguish between Agent Orange related diabetes and, you know, regular diabetes for a Vietnam vet? How do you recognize the symptoms of PTSD, of I mean, there's so many myriad things. The other thing they need to be trained in is in the VA. You know, when a vet gets diagnosed with something, they also get compensation. They also sign up for registries, right? There's all kinds of registries. I can't whip them off, you know, Agent Orange, this and that registry. And so that's where we collect information about these problems that veterans have, either in military bases or combat or whatever. All that information is going to be lost in the private sector. Do they know to tell a vet who has X problem for which they can be compensated that they should go to the VBA, and here's how? Do they know sign up for this registry? No, they don't. Rand did a study on 2 studies. Even if they even if they dismantle the entire VA, that's going to be the percentage of patients, because it's, you know, veterans are a very small percentage of the American population, and veterans enrolled in the VA and eligible for the VA are even a smaller percentage of the small percentage.
You've alluded to this challenge as well previously, but I just wondered if you wanted to elaborate on it. And that's the issue of the homeless patient population and how the VA manages the homeless population in contrast with that in the community.
Well, you know, I'm so glad you asked that. And building on Phil's, you know, Phil talked about best care anywhere and also healthcare. And the VA, I would argue that the VA is our only healthcare system in America. We have, I think, a broken medical treatment system. Healthcare is way beyond medicine. Maybe doctors don't like that, but, you know, it is. And the VA does healthcare as well as medical care. Not only does it do medical care, mental health care, but homelessness programs. The money that the VA and HUD and so forth, the feds put into dealing with veteran homelessness, reduces the homelessness problem in your city, which, you know, in other words, you know, if 14% of vets are homeless in San Francisco, you're taking 14% of vets off the streets and you do what these programs, there's gonna be 14% more people on the street. They also free up money that municipalities, would otherwise spend on dealing with homeless problems, free up money to be dealing with non-veteran homelessness or other social and economic problems in a city. So that is, another way that the VA serves the entire nation, not just veterans. And I think that's a problem that we have, is that many people think that the VA, VHA, and Veterans Health Administration only helps vets. So why should I care about it? And through the research teaching, these homelessness programs and other programs, it helps us all.
Okay, thank you. Let's turn to Phil for a few moments. In your book, Best Care Anywhere, you discussed why the VA care is different from that within the community. Do you think that those differences have changed over time since you wrote your book? And if so, how?
Well, when I wrote my book, first edition, I think came out in 2007, the VA had just gone through an extraordinary recreation of itself. We had a really inspiring story of a sort of revolution from below and a revolution from above. A revolution from below was coming into the 1970s and 80s. You had a lot of frontline VA employees that were facing very difficult working conditions, and they took it upon themselves to do things like hammer out the first electronic medical records just so that they could find their patients and find their medical records. And then eventually that revolution from below was met by a revolution from above in the form of Dr. Ken Kaiser, who was nominated by Bill Clinton to sort of take over the VA. At the time, a lot of people thought that the VA was going to just be folded into Hillary Care. At the time, it was like a sunset agency, but he took over this thing, and just this extraordinary organizational renaissance. And there's just all kinds of lessons to be learned about how to reform any organization. If you served in the military honorably, right, you are entitled to VA healthcare. And this would actually solve a lot of problems, because in many parts of the country, we still have excess capacity in the VA, way more capacity than we need, given the very shrinking size of the VA. So first step should be anybody who's a veteran should have access to the VA, no questions asked. You don't have to prove that your malady is connected to your service, right? And then in many places, there's more than enough capacity, both in physically and in terms of personnel, to bring in civilians like the spouses of veterans and treat all their comorbidities together, coordinate that care. I mean, it's totally win-win, both for the VA, the people who work it for it, veterans, and the larger public, right? We have this best care anywhere model. Why not make it more available to more people with less red tape hassle trying to keep all these people out?
Pretty interesting concept for sure. Phil, could you discuss the importance of whole health delivery, and can it be adequately delivered in the community care setting? And how might it be altered in the context of cancer care?
We would be looking at not just how do we treat people with advanced cancers, we would be also looking at how do we treat people before they get cancer, how do we help people to live with their cancers, right? And mindful of all of the different socioeconomic determinants of how each of us does with cancer, right? So the VA, one thing we haven't talked about much in this conversation, might have given a false impression. The average VA clinician, is actually a highly credentialed, likely teaches in an affiliated academic medical center. So we're not talking about people who aren't, real fighter pilots when it comes to being surgeons or being on the cutting edge of advanced high tech medicine, right? That VA has that too, right? But it also has this ability to coordinate the care among those various specialists and to look also at the whole person over time. And so I don't know how else to answer your question, except if we can just keep that vision in mind, right? And it helps to explain why the VA is already better and how much better yet it could be than the kind of healthcare most of us get. My advocacy has been so much for veterans as for the rest of us. It's like the rest of us deserve care as well as the VA has, right? So that's why my emphasis always is on expanding the VA, first of all, to all veterans, but then to all Americans,
Right.
because we all deserve this.
I think it's because the VA is a model that's why it's being attacked. Because, the forces that be do not want a government program that is better than the private sector. And that is a model for the private sector. And Phil talks about making VA hospitals available to non-veteran patients when there's low capacity. At White River Junction in Vermont, they have very serious mental health, shortages of mental health providers in the community. And they have opened the White River VA to, certain patients who need mental health care who aren't veterans. That's wonderful. But if you close VAs, then you cannot use that capacity. We cannot in America afford to lose one provider with the shortages we have, one facility, you know, in rural America, Phil alluded to this, it is a disaster, and it's a disaster that is about to get much worse. With closures of hospitals and lack of providers. You cannot have a functioning healthcare system in rural America because there aren't enough people. It has to be subsidized. It has to be subsidized. And the VA is a perfect you know, partner to partner with rural hospitals or rural providers in caring for rural veterans, as opposed to making it either or, or actually taking money away from the VA. And I looked at private sector provider capacity in every 50 state. It was a nightmare to do this, believe me. And it's just terrifying, the picture out there. Many rural hospitals have stopped giving chemotherapy. They've stopped obstetrical services. They've closed services. And, 123 million people live in areas with mental health care professional shortages. That's 47% of the adult American population. So, even if you thought outsourcing patients to the private sector was the greatest idea in the entire world, where is the care? 79 million people live in primary care. The VA was, a leader in that area.
So trying to provide a little bit of balance, are there any areas that you think that the community actually excels in care delivery?
This particular guy, this particular specialist, he's the best person in the world to do this operation that you need, right? But bear in mind, the VA has a long history of outsourcing care to appropriate specialists, right? So,
Mhm.
uh, again, we shouldn't conceive of this as a categorical question, outsource or not. The VA has always outsourced, and appropriately so, right? Um, in order to give people best care anywhere, give them a choice of where they get their care, right? The question is, how far do you take this? Do you take it so far that you destroy the integrity of the institution and eliminate its abilities to coordinate care and to build up these larger networks of appropriate specialists in the community?
Phil and I have been writing about this for a long time, Phil longer than me. And I think when Phil wrote his book, there was a lot of interest in Best Care Anywhere and in the way that he described the policies that make the VA so important, the best care anywhere, and to the kinds of programs and incentives that the VA has. And I think that that's in part why we're doing, this webinar. And I think the message really that we bring is you have a model of high functioning care that the American taxpayer has invested in for 100 years. It has problems. How could it not have problems? It's the largest healthcare system in America. The issue isn't, does it have problems? It's what does it do to solve those problems? And I think that we need to be talking to people in the media, in our church groups, in our families, to veterans about what are the advantages of the VA and how can they be built on, how can the private sector, the so-called community, which isn't very communal, learn from the VA. What does what can the VA learn from the private sector? If the VA has problems, you don't solve them by dismantling it. And we have a lot of problems in the private sector. We have huge shortages of primary care providers. Burnout is at an all-time high. Burnout in nursing. We have shortages of nurses. We have shortages of mental health providers. What are the models of care that would keep people practicing medicine, practicing as clinicians in mental health care? It's very challenging to work with sick people, you know? It's not fun because they're not at their best. We have a lot to teach the American public about healthcare from the VA, and it isn't an issue of either or. I think that's very important. The issue Phil raised, they've always used fee-based care to get veterans care they didn't need. It's just that there's a difference between an indiscriminate use that's designed to destroy a system and a judicious use that is designed to build up the system, deliver quality care, and integrate the VA into the community rather than pitting the VA against the community.
Most Americans learn about the mistakes of the VA in part because the VA is required to be more transparent than a private institution would be. What do you think we should know about the practices and service of the VA compared to community-based care? Thinking in terms of more public view of the differences. What
Well,
should we know and how should they obtain that information?
where the VA is, and that's um, as a public institution, it has comparative sunshine cast on all of its operations in a way that the private sector doesn't. So going back 30 years or so, when Ken Kaiser took over the VA in the late mid 90s, he for the first time, he asked the staff, created a system for measuring how many medical errors had occurred, were occurring at the hospital, and then published those numbers. Um, Nobody else in American healthcare even kept track of their medical errors, let alone publish them. For those who don't know or don't remember, that was the time when the so-called waiting list scandals became national news, being promoted by activists in Congress. And one of my frustrations on that story was, yeah, there were some long wait times in some VA hospitals. Uh, why was that? Well, first of all, because VA healthcare was so good compared to other healthcare providers that a lot of veterans were showing up at the VA wanting to have care there, right? So that was one strain on the system. Another strain on the system was uh, that a lot of veterans were retiring to Sunbelt cities, and so we had a lot of strain on places like Phoenix and Orlando, and all kinds of excess capacity in places like Pittsburgh and Detroit. But the big thing was nobody basically even started to answer the question, what are wait times like in the rest of the healthcare system, right? How long do you have to wait to see a urologist? There's like all these problems in the VA. Wait times are one of them, but compared to what, right? And if wait times are actually worse in the non-VA healthcare system, how much sense does it make to outsource more care to the non-VA system to make their already excessive wait times even longer?
I want to thank Suzanne and Phil for their time and expertise, and hope that this has been of value to you. Thanks very much.
Thank you.
I will echo Mary's thanks, Suzanne and Phil. That was just, I could do this for another hour. So thanks for your passion, your commitment to veterans and their healthcare benefits and their rights, and more so bringing a basic understanding to a larger audience of the problems that exist and the way VA has dealt with those problems to still maintain high quality healthcare for our veterans. So I cannot thank you more for your commitment and your time today.
Thank you for giving us this opportunity.
Yeah, it's
Great.
really wonderful. Thank you so much.